Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. I'm Lewis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. Excuse me. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in the meeting control toolbar. To toggle that meeting control toolbar on, press the Alt key once, and then press it a second time to make it stay on. As always in our sessions, only the speakers will have audio. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900-9128 or 1-646-558-8656 and use the webinar ID 760-897-977. I do want to remind everyone that this webinar is being recorded and it can be accessed on adapresentations.org website in the archives section next week. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. This series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990, the ADA. Upcoming sessions are available at adapresentations.org under the Schedule tab, then follow to Healthcare. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific Time. By being here, you are on the list to receive notices for future webinars in this series. Those notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the Healthcare Schedule webpage at adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform. The speakers and I will address them at the end of the session, so feel free to submit them as they come to your mind during the presentation. To submit your questions, type and submit them in the chat area text box, or if you are using keystrokes, press Alt and H and enter your text in the chat area. If you are listening by phone and not logged into the webinar, you may ask your questions by emailing them to adatech@adapacific.org. That's adatech@adapacific.org. If you experience any technical difficulties in the webinar, you can send a private chat message to the host, typing in the chat window. Type your comment in the text box and enter. If you're using keyboard, again, use Alt-H to access the chat box and enter using your keyboard keys. Or you can also email us at adatech@adapacific.org, or you can call 1-510-285-5600. Today's ADA National Network Learning Session is titled Centers for Medicare and Medicaid CMS Efforts to Increase Healthcare Access and Quality of Care for People with Disabilities. During the year of the 30th anniversary of the ADA, it's time to reflect on the state of various rights and access for people with disabilities. Work on improving healthcare access and equality is particularly important because although great strides have been made, there is much progress needed to be made. This webinar features speakers from the Centers for Medicare and Medicaid Services who will identify the efforts being made in CMS's Office of Minority Health and the Medicare-Medicaid Coordination Office to provide information and resources to medical organizations, providers, and consumers to increase healthcare access and quality of care for people with disabilities. Today's speakers are Karen Gentile. Karen is a public health analyst in CMS's Office of Minority Health. Karen is a licensed clinical social worker and attorney with over 25 years of professional experience. And prior to being at CMS, she worked as a public health advisor at the Substance Abuse and Mental Health Services Administration, SAMHSA, in the Center for Mental Health Services. Sonia Karpiak-Bowen is a public health professional with 25 years of experience working in Medicare and Medicaid quality improvement, performance management, and program policy and operations at the Centers for Medicare and Medicaid Services. Within CMS's Medicare-Medicaid Coordination Office, she currently manages state demonstrations in Ohio and Illinois under the Financial Alignment Initiative to improve integration and quality of care, reduce cost, and coordinate benefits between Medicare and Medicaid for people who are dually enrolled in both programs. She also co-leads program planning and administration of the Resources for Integrated Care, which provides technical assistance, education, and practical tools to healthcare providers, managed care plans, and organizations working to integrate care for dually enrolled beneficiaries. So Karen and Sonia, I will now turn it over to you.
Thank you, Louis. This is Karen Gentile. Could you go to the next slide, please? Okay, today we're going to be presenting on the CMS's efforts to increase healthcare access and quality of care for people with disabilities. Please, next slide. On the agenda today, if you go back to the agenda, yes. First, we're going to be talking about the CMS Office of Minority Health, or OMH, and then OMH's approach to achieve health equity. CMS OMH's health equity work for people with disabilities. And then Sonia will be talking about the Medicare and Medicaid Coordination Office, Disability Competent Care Overview, and then the healthcare workforce support for providing disability competent care. Next slide, please. Okay, next slide, please. Okay, Louis already introduced me, but just so you know, I lead the portfolio on health equity for people with disabilities in OMH, in CMS OMH. Next slide, please. Okay. When the Affordable Care Act was introduced, it called for the establishment of 6 offices of minority health within HHS agencies, including CMS's Office of Minority Health. These offices joined forces with the HHS Office of Minority Health and the National Institute on Minority Health and Disparities to lead and coordinate activities that improve health and of minority populations. Next slide, please. So the mission of the CMS Office of Minority Health is to ensure that the voices and needs of the populations we represent, racial and ethnic minorities, sexual and gender minorities, rural populations, and people with disabilities, are present as the agency is developing, implementing, and evaluating its programs and policies. And the vision of the office is that all CMS beneficiaries have achieved their highest level of health and disparities in healthcare quality, health, and disparities in healthcare quality and access have been eliminated. Next slide, please. So in line with the public health field at large, CMS-OMH focuses on the effects of social determinants of health, which are the conditions in which people are born, grow, live, work, and age, and how these social determinants of health, or the effect that they have on the health of all populations, including people with disabilities. So this slide just says a little bit more about social determinants of health. Next slide, please. As part of the CMS Equity Plan for Medicare, CMS-OMH developed a framework in the path to equity that consists of 3 interconnected domains. And I'll work through those domains in this presentation. One of them is increasing understanding and awareness of disparities. Second is developing and disseminating solutions. And then number 3 is implementing sustainable actions. Next slide, please. So in 2015, CMS identified 6 priority areas based on a review of evidence and stakeholder input to achieve equity in Medicare as part of the CMS Equity Plan for Medicare. And these priority areas are currently being updated, but there will be many similarities. And I wanted to point out in this very sort of busy slide of all the different priorities that 2 of the priorities directly address healthcare access and quality for people with disabilities. Priority 5 is to improve communication and language access for individuals with limited English proficiency and people with disabilities. And then priority number 6 is to increase physical accessibility of healthcare facilities. For more information about this and actually everything I'm talking about in this presentation, please just go to our website and you can learn more about the equity plan, etc. Next slide, please. So in the path to equity framework that I mentioned before with the arrow, the first domain is increasing understanding and awareness of disparities for people with disabilities. There is a lack of consistent standard disability data throughout the field, with different disability definitions and different measures across instruments. This makes it very difficult to make valid conclusions about healthcare access and quality for people with disabilities, and further presents challenges in formulating solutions in disparities. Next slide, please. So to advance more standardized data collection, CMS-OMH has been educating our partners on the 2011 HHS data standards related to disability. So as you can see on this kind of busy slide, the HHS released a report that promulgated different data standards for measuring different race, ethnicity, sex, primary language, and disability status. And for disability status, it's these 6 questions that are very important. And I'll run through them really quickly. One is, are you deaf or do you have serious difficulty hearing? Are you blind or do you have serious difficulty seeing even when wearing glasses? Number 3, because of a physical, mental, or emotional condition, do you have serious difficulty concentrating, remembering, or making decisions? Number 4, do you have serious difficulty walking or climbing stairs? Number 5, do you have difficulty dressing or bathing? And number 6, because of physical, mental, or emotional condition, do you have difficulty doing errands alone, such as visiting a doctor's office or shopping? So those 6 items have been placed is actually mandatory to be placed in all HHS population level surveys. But the goal of CMS-OMH is to educate our partners on and the importance of using this to standardize data across different data sets and instruments, with the goal of exploring incorporating these standards into healthcare data collection further. So that's just an example of the way that we're working in our office. Next slide, please. Okay. One of the things our office does is to contribute to the field and to work with within CMS is data analysis related to health equity. So on this and the next slide, I've included 4 publications relevant to disability health equity. And I do encourage you, there's links on these slides, and you can also access all of this on our website. So please take a look, but I'll just kind of quickly run through what I think are important highlights. One is the first one is the journal article, Characteristics of Medicare Beneficiaries with Intellectual or Developmental Disabilities. A highlight is that the study found that the Medicare fee-for-service group with intellectual or developmental disabilities that were studied had high prevalence rates for chronic physical and mental health conditions, overuse of emergency department, and high rate of 30-day admission. So that's the one. The second one here on the slide is a data highlight. How does disability affect access to healthcare for dual eligible beneficiaries? And this study found that people who are dual eligible for both Medicare and Medicaid with self-reported disabilities are more likely to experience difficulty accessing needed medical care than beneficiaries without disabilities. However, among all the beneficiaries who have experienced being unable to get needed care, those with a disability reported higher healthcare utilization rates than those without a disability. So that's an interesting finding. Next slide, please. The third data analysis publication from our office that I wanted to highlight is this, does disability affect receipt of preventative care among older Medicare beneficiaries? Key findings of this study show that Medicare beneficiaries with disabilities are less likely to receive cancer screenings and more likely to receive routine preventative care. And among Medicare beneficiaries 65 or older, females with disabilities are less likely to receive mammography screening than those without disabilities. A third finding is among Medicare beneficiaries 65 or older, those with disabilities are more likely to receive pneumonia vaccination than those without a disability. So for more information, please look at these. The fourth study is the Medicare fee-for-service beneficiaries with disabilities by end-stage renal disease status. Key findings of this one. 54% of Medicare beneficiaries with disabilities and end-stage renal disease had 6 or more chronic conditions as compared to 20% of the beneficiaries with the disability but without ESRD. And among hospitalized beneficiaries, Medicare beneficiaries with disabilities and ESRD had higher rates of 30-day hospitalization readmissions, were high utilizers of healthcare compared to beneficiaries with disabilities but without ESRD. So those are 4 that I wanted to highlight for you. Next slide, please. Okay, it's long been understood that populations in our office serves, including people with disabilities, are highly affected by chronic disease conditions. In order to address chronic conditions with an equity lens, CMS OMH designed an interactive map called the Mapping Medicare Disparities Tool. This is just, there's a screenshot of the tool on the slide. The tool identifies areas of disparities between subgroups of Medicare disparities, for example, racial and ethnic groups, age and sex, and then in chronic conditions, health outcomes, healthcare utilization, and spending. I encourage you to explore this tool at the link on this slide. It's a way of really understanding how disparities exist in throughout our country. And there's a population view, hospital view, and even by county. Next slide, please. Okay. The second domain of the Path to Equity framework that I mentioned at the beginning is developing and disseminating solutions. Next slide, please. So it's important to note that CMS OMH does not own any of the programs or policies within CMS. So we try to work with other CMS components to embed equity into the work that they own. We are advisory. One example of this collaboration is the work our office did with the Center for Medicare within CMS on adding payments coding for extended visits to the physician fee schedule within Medicare. This innovation can be very important for people with disabilities because there's often a need for longer appointments, extended appointments to provide reasonable accommodations to discuss and to discuss complex medical situations. So that I just wanted to put this out as an example of how we work with different components within the agency. Next slide, please. Okay. In developing and disseminating solutions, our office continuously engages with stakeholders to inform all of the work. So important stakeholders include people with disabilities. And one thing I will say about that first bullet there is, here's an example. We work very closely with the Disability Employee Resource Group within CMS, which includes CMS employees who have different disabilities and different levels of expertise on CMS policies and programs and their allies, right? Although the main focus of the group is diversity and inclusion of the CMS workforce, the group has provided valuable guidance and feedback on our resources. So that's the kind of sort of continuous feedback we engage in. Other valuable stakeholders, of course, include disability serving organizations, providers and health systems, among others. So gaps in resources are often identified through engagement with different stakeholders. And our products are then developed using evidence-based information and best practices based on those gaps that we see. And our products then reviewed before public release and after by those stakeholders. And we kind of, even afterwards, we're looking for feedback and we will make changes as they go along. The office uses a variety of stakeholder communication methods, such as formal listening sessions and formal and informal stakeholder calls, et cetera. CMS also maintains interdepartmental federal partnerships to make sure we're breaking down silos and foster collaboration between all the different federal entities that are doing work in this area. Next slide, please. So one way we engage with stakeholders and partners is to provide relevant information in response to identified need. And of course, one example of responsiveness that we've had to respond to is the information we provide about COVID-19. We know, of course, that COVID-19 has presented serious challenges to vulnerable populations, including people with disabilities. And one way we keep our stakeholders informed is through our COVID-19 webpage. Please take a look at this. The link is provided here, and it's got information, federal resources, both for providers and consumers, and there are some resources that are available in other languages as well. Next slide, please. Next slide, please. Okay. In addition, CMS OMH has developed a resource for consumers regarding COVID-19. This first one that I'm talking about is entitled Coronavirus and Your Health Coverage, Get the Basics. You can find out more information. This is the 3 pages that you'll see when you access it. Then this, next slide, please. And another consumer resource we developed on COVID-19 is called Stay Safe, Get the Care You Need at Home, giving an overview of telehealth, managing ongoing health conditions and prescriptions and other tips. Next page, please. Or next slide, please. Okay, CMS has also developed resources for providers addressing healthcare accessibility for people with disabilities. Next slide, please. One of these resources is an issue brief titled Increasing Physical Accessibility of Healthcare Facilities. And it covers impact of physical accessibility on health outcomes with people with disabilities, laws and regulations to promote accessibility, and examples of federal and state level efforts to increase accessibility. Next slide, please. Another resource, provider resource, is entitled Modernizing Healthcare to Improve Physical Accessibility, and it's a resource inventory. It's got standards and guidance on physical accessibility, assessment tools, and tips and resources to support improvements. Next slide, please. Our office also has developed several resources that are not specifically focused on people with disabilities, but could be, of course, useful for providers serving everyone, including people with disabilities. If you go to the next slide. I wanted to point out a few of them, although there are way more than I have time to talk about. So adults with disabilities have a higher prevalence of diabetes than those without, and experience multiple challenges that may impede diabetes prevention, including barriers to care, access, and lower level of physical activity. Therefore, resources that having to do with diabetes is very relevant to, to those serving people with disabilities. The first I wanted to point out is the Diabetes Management Directory of Provider Resources. And then the second one is a culturally and linguistically tailored type 2 diabetes prevention resources inventory. So please take some time to check those out. Next slide, please. Another really relevant resource is the Chronic Kidney Disease Disparities Educational Guide for Primary Care. And the goals of the guide are approaches to identifying chronic kidney disease, approaches to treatment and monitoring of chronic kidney disease progression, and approaches to centering care on the patient. And the guide talks about the need for really good and comprehensive data collection, including counting people who have disabilities, and also discusses the need for culturally competent communication of all patients, including those with disabilities. So this is an important guide. Next slide, please. Another important provider resource is the Reducing Disparities in Readmissions. And the goals, the guide are to provide an overview of key issues related to disparities in readmissions, set of activities that can help hospital leaders address readmission in the population, and strategies aimed at reducing readmission in diverse populations. Actually, the information I just was saying on the other slide about data collection was relevant to this one. Instead, talking about the need to collect information about people with disabilities and culturally competent communication. So also an important one that I hope that you will look at this resource as well. Next slide, please. Okay, another set of resources from our office addresses language and communication access. The first resource here is the guide on developing a language access plan. Now, it identifies ways providers can access their programs and develop language access plans to ensure persons with limited English proficiency have meaningful access to their programs. So of course, not only relevant to people with disabilities, of course, but every provider could really benefit from thinking about language access plan. And then more relevant with communication access, we have another resource, Building an Organizational Response to Health Disparities, 5 pioneers from the field. And these are case studies of private sector healthcare organizations and how they identified and addressed health disparities. And so there are different health disparities that are included in this resource, but one of these case studies is of Frederick Community Hospital and how they engaged deaf advocates and other hospitals to build a really robust American Sign Language interpreter service that's in person and available 7 days a week. So that might be a really important one for people to look at, relevant to people with disabilities. Next slide, please. Another important resource is that really would be for all providers of all populations is the practical guide to implementing the national class standards. And the class stands for culturally and linguistically appropriate services. And it's really to enable organizations to implement the national class standards to improve health equity for racial, ethnic, and linguistic minorities, people with disabilities, and sexual and gender minorities. Practical tools and examples. So I really encourage you to look at that as well. Next slide, please. Now, I noted earlier that CMS OMH has developed consumer resources to address COVID-19. We also have developed the following consumer resources relevant to people with disabilities and other consumers as well. Next slide, please. A really important resource that we really are trying to disseminate as much as possible is the Getting the Care You Need, a guide for people with disabilities. This guide has information on the rights of patients, how to work with providers to get the care they need, contact information to file a complaint, checklist to prepare before, during, and after appointments. And it has a lot of very practical information. It's available in Spanish, Mandarin, Arabic, Vietnamese, Korean, and Russian. And also available in Braille, and someone can request a physical Braille copy by contacting the link in this slide. So I definitely encourage you to check that out. And also if you happen to have if any of you in this audience have any suggestions of organizations that serve people with disabilities that could benefit from this resource, please contact me with the contact information you'll get later, especially if they serve people with disabilities that have limited English proficiency. We really want to disseminate this resource as much as possible. So please keep that in mind. Next slide, please. We also have 2 video vignettes, one targeted to consumers and one to providers, in which people with disabilities, you can see right there in on the slide, describe their experiences with accessing healthcare. And for the consumer video, it also has some advice, some sort of tips on self-advocacy, and the one for the providers is tips on increasing healthcare access and quality for people with disabilities. And they're both about 2.5 minutes long. They're short, but very effective. Next slide, please. And for all healthcare consumers with disability, with not disability, of all populations, our office has a suite of resources available on our website called Coverage to Care. And these resources help consumers understand their health coverage and connect to primary care and preventative services. And the link is provided right here, can also be accessed through our website. There are many different resources on there, and some are actually even for providers and healthcare organizations to help disseminate this information as well. So please look at that website or that page. Next slide, please. And then the final domain of the path to equity that I was talking about is implementing sustainable actions. Next slide, please. Our office does that through by offering the health equity technical assistance. It's one-on-one technical assistance to help healthcare organizations reduce disparities. This technical assistance might cover things such as resources or guidance on how to collect or analyze data, how to begin a quality improvement activity, interventions for a particular population or type of provider, or even how to create a health equity governance structure, and among other things. And we also provide guidance on developing a disparities impact statement that really can help an organization focus on sort of what's there now and what the goals are to reduce disparities and increase health equity. So for more information, the link is there, healthequityta@cms.hhs.gov, and it also can be accessed through the website, the OMH website. And the last slide that I have, next slide, please. Next slide, please. Okay, so, oh, I'm sorry, one more. If you can go back to the last slide. Yes. So for more information, as I've been saying over and over again, please access the CMS Office of Minority Health website. There are many other resources I did not go over on this website that could be useful for providers and organizations serving people with disability and for consumers with disabilities themselves. So I really encourage you to take a look at what we have. So that ends my part, and I think I'll hand it over now to Sonia. Thank you.
Good afternoon, everyone. I work in the Medicare-Medicaid Coordination Office, and as, next slide, please. Next slide, please. As many of you know, Medicare and Medicaid were originally created as distinct programs with different purposes. And as more people depend on both Medicare and Medicaid for their health care, including people with disability, there's an increasing need to align the two programs to improve care delivery and beneficiary experiences while also reducing administrative burden for providers, plans, and states. So throughout my presentation, you'll hear me use the term dual eligibles and duals in reference to people who are dually enrolled in both Medicare and Medicaid. And for context, a little bit of context on the duals population, 70% of duals have 3 or more chronic conditions, 41% have at least one mental health diagnosis, and 39% are eligible for Medicare based on disability. As such, providing accessible health care for people with disabilities is an important driver of the work that we do. And so our office, the Medicare and Medicaid Coordination Office, was created to address some of these problems around fragmented care and misaligned incentives for both payers and providers who serve people who are dually enrolled in both programs. We work very closely with federal partners, including Karen's office, states and other stakeholders to try to eliminate some of the regulatory conflicts that occur between Medicare and Medicaid rules, as well as simplify the processes in place for dual eligibles to access covered items and services. And one particular area of our work is providing technical assistance, one to states through the Integrated Care Resource Center, and also to health plans and providers through the Resources for Integrated Care. I will be highlighting some of the resources and tools that are available through the Resources for Integrated Care, which I'll also call the RIC, that are particularly relevant for organizations working to serve people with disability. And I'll spend most of my time focused on an introduction to the disability competent care model. Next slide. The disability competent care model was developed by people with disabilities along with experts in service provision and a number of pioneering managed care programs serving people with disability. It was first implemented in 2013, and it was developed in part to address gaps in health education. The Disability Competent Care Model, or DCC model, is about understanding that people with disability are diverse and each person has unique needs. And it stresses that as a healthcare professional, you need to understand whom you're serving. And rather than focusing on a diagnosis, this model focuses on providing timely care and support for maximum function and addressing barriers to integrated accessible care. And one of the things that the model requires for healthcare professionals, is to collaborate across disciplines and care settings. And to effectively apply this model, healthcare professionals may need to enhance or develop new skills in interdisciplinary collaboration, as well as in-person or participant-centered care. Next slide, please. And I want to mention before moving on that this resource and the other resources that I'm going to mention are all available for free online, and the websites for those resources will be presented towards the end. So in talking about disability competent care, the 3 core values of this model intentionally emphasize treatment of the whole person with a focus on the individual's needs and preferences, as well as respecting an individual's choices, and also eliminating medical and institutional bias. And so at the practitioner or at the practitioner level, it's about becoming aware of any disability-related beliefs or biases that can interfere with the ability to provide effective care. And it's about listening to and learning from the person who is receiving care. And then at the institutional level, the model is about moving away from the medical model related to fixing a person through professional intervention towards the participant-centered model that recognizes each person as the primary expert in their own life. Next slide. So the 3 core values that I just went over are supported by 7 functional pillars. And these are the building blocks of the disability competent care model. And I wanted to mention that there are separate online modules that are available through the Resources for Integrated Care website that introduce each pillar in greater detail. And what I'm going to do is highlight them quickly here, because there's not enough time to really go into depth on them. So the very first step is understanding the DCC model itself and understanding different disabilities within the population being served. And then the second pillar is focused on participant engagement and implementing person-centered care. The third pillar is ensuring that healthcare participants have access at all phases of the healthcare delivery and in community participation. The fourth pillar focuses on developing and integrating responsive primary care. The fifth pillar is focused on identifying care coordination needs across services, which would include care transitions and also leveraging community supports. The sixth pillar is establishing flexible long-term services and supports. And then the seventh pillar centers on coordinating behavioral health services to ensure that participants do receive comprehensive care. All right, next slide. So it's a lot to take in, and it's a lot of information. There's a question about, if you're an organization or you're a provider and you're interested in becoming, in learning more about the disability competent care model and how you how you apply that to your organization, it can be a bit overwhelming. And so, hang on just a second. So the question is, so where do you start? And like many things, you start with assessment. And there's a process. There's a resource. So this is one of the resources that are available on the resources for integrated care. And it's meant to help organizations assess, do an honest assessment of where their organization is in each of the 7 pillars. So it's kind of like a module approach. And so what the assessment does is a self-assessment, and it's designed to facilitate looking at current practices and processes within your organization. And this could range from direct care delivery all the way to business operations. And this tool was developed with input from subject matter experts and field tested, and is recognized as best practice. And this tool, the Disability Competent Care Self-Assessment Tool, primarily focuses on meeting the needs of individuals with functional limitations. However, I wanted to note that this model and this tool is applicable to removing barriers to healthcare more broadly to people with disability. And so as part of the process, an individual or individuals interested who work in a health plan or system, they'll be asked to walk through the assessment tool. And there's a scoring tool that helps identify strengths within the organization, as well as prioritize opportunities for improvement. For example, is there low-hanging fruit that's been identified, whether that's within one of the pillars or multiple pillars that may be related? And then other questions that should be asked are, what's a reasonable timeline to try to target some of these gaps? And the other important consideration is based on available resources, because we know that it's not practical to try to target all of the gaps at the same time at once. So based on available resources, does it make sense to prioritize on one pillar versus another? And can any of the pillars be addressed in tandem with each other? For example, can care coordination be addressed with behavioral health or with LTSS services? So there are a number of ways to think about it and go about coming up with a process and a plan to improve. Next slides, please. So a complementary resource is the Disability Competent Care Self-Paced Training Assessment Review Tool. And what this does is it allows an organization to assess the disability competence of the organization's training materials. It also allows the organization to identify opportunities for enhancing their existing training, and it's informed by the DCC model. And this resource also offers a tailored selection of additional resources that can help organizations improve the effectiveness and completeness of their disability-related training materials. And one of the important things with this resource, as well as the assessment tool, is that the results need to be communicated clearly with key staff who would be involved in the work of implementing the model. And this is also, the disability competent care model is seen as an ongoing process. And so it's important, once implemented, to revisit both tools periodically to track progress on where you are and to reprioritize activities where needed. And then in addition, to these resources, there's also there's a resource guide focused on the DCC START tool, and it's organized by assessment topic and subtopic area. So it's really meant to help inform organizations as they're moving forward. Next slide, please. So I wanted to highlight here a recent article that came out in the Disability and Health Journal called "A Call to Action, Preparing a Disability Competent Healthcare Workforce." And we worked on this article through the Resources for Integrated Care and also partnered with the Alliance for Disability and Healthcare Education, which is through the Ohio State. And what it did was, one, it issued a call for action on needed education practices and research to ensure that the healthcare workforce is prepared to provide quality care to individuals with disability. And what it does is it highlights two initiatives. One is the DCC model that I just highlighted, with the purpose of highlighting disability training for healthcare professionals who are already practicing. And then on the other side, the Ohio State's Disability Competencies Project, what that does is it is focused on a disability training curriculum for future healthcare professionals, acknowledging that we need to address both folks who are already practicing as well as those who will be coming into the healthcare profession. And we're starting to see this curriculum on disability competencies we're starting to see it in different medical curriculum. And included here is a link to that article if you want to learn more, or if you whether you want to try to advocate within, whether you're in the school system, university system, or within organizations trying to learn more. Next slide. So I did want to mention that about 8% of dually eligible people under the age of 65 have an intellectual or developmental disability. So the resource that I'm highlighting here, the My Health, My Life Toolkit, this is a toolkit that's designed to help individuals with intellectual or developmental disabilities, as well as their family members or guardians and their provider support team, to kind of navigate communication and strengthen the relationships among the person receiving care as well as the care team. And this particular toolkit has 4 tools, and one is looking at personal health records so that folks can bring information to their appointments to better inform their providers. And then the second tool is a hospital companion guide, which prepares individuals who are in the hospital. It prepares them and their families or guardians for the transition home afterwards. There's also a discharge planning tool that is primarily designed to help the individual's provider support team in the discharge planning process. And then there's also a self-advocacy empowerment tool that allows a person to help plan for their services and supports as their needs and preferences evolve over time. And not shown here, I also wanted to mention that on the Resources for Integrated Care website, there are also webinars that focus on improving the coordination of care, of services and supports for people with intellectual and developmental disability. And there are special topics around aging and pain and pharmacology. Next slide. I also wanted to mention a recent resource that focuses on incorporating language into person-centered care. And Thoughtful language choice by health plans and providers really supports a meaningful partnership with individuals receiving care. And we know that using words and terms to describe who a person is recognizes that, as I mentioned previously, that people are experts in their own lives and in their health and needs. And we often find that focusing on things like language and communication is kind of like a building block and a starting place for helping to shift the paradigm from a medical model to a more person-centered model, and to help conceptually people who are providing care to understand what person-centered care or participant-centered care actually means. And so there are two resources. One is a tip sheet, and then extracted from that tip sheet is a one-page printable reference around person-centered language. And between the two of them, they offer guidance and examples around using person-centered language, and also offer additional resources or reference additional resources for enhancing person-centered practice. So if this is something, this is a resource that might be helpful on the education side as well, which supports the first pillar in disability competent care on understanding the model itself. And so person-centered care is an important part of that. Next slide, please. So additional resources that we have on the resources for integrated care, there are links here to the full suite of DCC resources, including the webinars that I had referred to, as well as the assessment tools themselves and tip sheets. So I encourage folks to take a look at that. And then there's another link on the RIC website that provides access to the different resources that I mentioned around understanding the health and support needs of people with intellectual and developmental disability. And one other resource that I do not have a slide for, but I did want to mention, it's a new resource focused on flu vaccines in the context of COVID-19. There's a webinar that we just had, I believe, last week around promising practices for promoting flu vaccinations for dually eligible beneficiaries. And this resource is really helpful because it captures the perspective of different health plans and providers on some of the innovative things they're doing to promote flu vaccinations and to remove barriers for getting those vaccinations. So I encourage you, if you go to the main resources for integrated care website, you'll find that flag under new resources, but really encourage folks to check out those resources. Next slide. And if you want to stay connected and learn when new resources are coming out, there's information here on the listserv and also our Twitter feed. And I wanted to stress that a lot of the resources that are developed through the resources for integrated care are really informed by what we hear from the community as what are the needs. And so I really encourage folks to reach out to ric@lewin.com, because we really do take those suggestions into consideration, and really drives a lot of our work. Next slide. And that is the end of my presentation.
All right, thank you very much, Karen and Sonia. Those are really great resources for everybody to have near at hand. And so for all of you listening, this is the time to submit your questions. We have some time to ask Karen and Sonia about what they've been talking about or similar things. So I'm going to start off with a few while you all continue to enter your questions in the chat area. The first question Someone asked, I am wondering what analysis, if any, that has there been for young children birth to age 10 with eligibility determination for Medicaid under Katie Beckett based on developmental disabilities. It has been my experience over many years that there appears to be an age bias applied to this age group. They are almost always determined not eligible based on the level of care, i.e. young children already require 24/7 supervision. The challenge with this is, one, it's inaccurate. A child with disabilities level of supervision requirements far exceeds that of typical developing peers. And two, a lack of access to Medicaid at a young age creates barriers and disparities to children having consistent access to medically necessary supports that can mitigate lifelong impacts, saving money. I personally believe this is a violation in state policy as it applies to the Olmstead decision and the ADA. And then she adds a clarification. The policy actually states that Katie Beckett Medicaid is available for birth up. The violation is in the implementation or interpretation of level of care as it applies to younger children who years ago would have been institutionalized with a diagnosis of being, quote, feeble-minded.
Okay, this is Sonia. I'll jump in. So there are a lot of policy implications to this question. And I don't think Karen is either the right person to address this, but what I would like, if Louis, you could make sure all of this information that's in the chat is given to me, and if it looks like Anna Lake is the person posing the question, if you could get me the information on that, that's something I can follow up. It's with the policy folks on the Medicaid side who would be much better able to address this. And then my only request on this is that if it's related to a particular state, that would be helpful to know as well.
Okay, we will record those. And Anna, do note the addresses of Sonia, her email address there on the screen, sonia.bowen@cms.hhs.gov, if you would like to just write her directly and ask the question. All right, the next question. You mentioned some resources that were available. This came up during Karen's talk, just so we have clarification. You mentioned some resources available in Braille. Most people who are visually impaired or blind become so later in life and do not read Braille. Do you provide materials in audio and large print, which is a much more used format by seniors and people living with vision loss?
Okay, so this is Karen. You bring up an excellent point. Absolutely. You know, the answer is that nothing that I know of our materials in OMH are in audio or large print, and Sonia can talk about her office. But, and I just to confirm, I just looked it up on our website. I could not, find evidence of that. But yeah, I will definitely take this back to my colleagues in OMH, because this is the type of feedback that we really need to drive our work and to make things more accessible. That's the whole, the whole vision of our office, is to be able to have, to promote accessibility in healthcare, and then of course make materials accessible, of course. So I will definitely do that. And if you would like to stay in touch about this issue, please contact me. You're welcome to do that with this, but I give my word that I will certainly take it back.
And the second question from that same person was, I wonder if you have information on insulin pumps and continuous glucose monitors that use voice output. Diabetes is one of the leading causes of adult onset blindness, and yet I do not know of any devices other than glucose monitors that have voice output. This truly impacts preventative care for diabetics living with vision loss.
This is Karen again. What I can do is follow up with my colleague in OMH that is the Office of Minority Health that is works more primarily on with diabetes, with the issue of diabetes, because I am not personally aware, but that doesn't mean there isn't some work being done on this. So it within my office. So I don't know if that's what I can say, that I can follow up. And if you'd like to keep in touch, please let me know. And I don't know if Sonia has anything to add.
So I did want to mention that this is going back to the previous question around resources being available in audio and large print. We do have an office within CMS that is tasked with taking requests from people who need any of the materials, not just materials from Karen's office or from my office, but any requests for materials that need to be in an accessible format, including audio and large print. That is a function and a resource that is available, even if what you find on the web resources is not necessarily accessible. So I did want to put that out there.
Excellent.
All right. To the person who asked this next question, and to all of you, the PowerPoint will not be mailed to you, but it is available at adapresentations.org. Today, it's in the schedule page. Tomorrow, it will be in the archive section. So feel free to refer to that if you would like. Next question. Do either of the presenters have any advice for an attorney with a significant disability who would love to work at CMS in this area one day? That is, any advice for getting a foot in the door to start such a career? Thank you.
I think I have to think about this, but I think that there are efforts, particularly through the Disability Employment Resource Group, around this area of increasing representation within the agency of people with disability. And so I think it would be better if it was like a one-on-one follow-up on that. If that person wanted to email me, I can certainly try to follow up on that.
Okay. Have you done research into accessible materials available for hospital admissions, permissions for care, and discharge paperwork?
I am not aware of that. No, in the Office of Minority Health, I don't think we have done that research.
Yeah, we have not either under the Medicare and Medicaid Coordination Office, but this is certainly something that we can take back into consideration as we develop different work.
Okay. All right. Great. And regarding the very first question, Anna Lake puts her own email address in there. If either one of you would like to talk with her directly. John Sorensen maybe is supporting one of your answers by saying CMS can provide materials in the needed formats. I don't know if you are familiar with him, but that's an answer that was up there. Are the guides available in hard copy upon request? For example, your care transition toolkit looks great, but it is huge and would be hard to print for a person with a disability of limited financial means.
That is something we should be able to assist with, and that may be through the office I mentioned before. What I can do is after the presentation is follow up with Lewis and let him know, because I don't know offhand the contact information for requesting, for fulfilling those kinds of requests. So I'd like to be able to follow up so that could be added on when the presentation is posted. Will that work?
We can try that, or to the person who asked about this, if you are interested in this for yourself, you have their contact information, and you could actually contact them directly to ask for the hard copies from them directly. Other than that, if you want to list a link, I don't know how we could do. Well, we can talk about it, Sonia. We can put whatever we want up in the archive. If you have some instructions on how to get hard copies of materials, we could actually post that as part of the archive, if that helps.
Okay, sure. I'll follow up on that.
Another question asked about can the recording be shared on social media? Now, I am going to assume that you're talking about this recording, and this recording goes on to adapresentations.org. It will be in the archive section of healthcare starting beginning of next week, and then you can use it from there. If you want to link to it through your social media, we're happy to have you do that. That's fine. All right, next question. Oh, hold on. Got clarification about the hard copy. I don't need it for myself, but I work for a disability rights group and would love to be able to give them out as needed. Okay, so again, we'll try to put up that information on the archive, or you've got the contact information for Sonia and for Karen, and if you want anything in hard copy, you can certainly contact them directly once you know how many you need or what your needs are on that. Okay. Next question. This presentation really resonates with some of the work of the North Carolina Council on Developmental Disabilities has done, such as our From Planning to Action, Integrated Collaborative Care for People with Intellectual and Developmental Disabilities initiative, focused on increasing primary care provider capacity to effectively treat people with IDD here in North Carolina. And there is a link there if people are interested in the chat to that work. I don't know if you guys have a reaction to that, if you're familiar with that or not.
So I'm not familiar specifically with North Carolina's program, but I'm definitely interested in checking that out.
As am I, definitely.
Okay. And so let me just ask another question here. So Karen, on Office of Minority Health information, which looked really great, that seems to be, that went up, within the past year or so? These are relatively new documents. Am I remembering that correctly?
It's been ongoing. So the last several years, the office has been around since the beginning of the Affordable Care Act. So that is, 10 years? And so a lot of the resources have been over the years.
Uh-huh.
Yeah.
Okay. And I know that Sonia, the Medicare-Medicaid Coordination Office, certainly has been doing this with the RIC and the DCC for a while as well. All right, new question that just came in. The initiative that I just read off from North Carolina saw the Autism Society of North Carolina partner with Campbell University Medical School to introduce first-year medical school students on effectively understanding and treating, whoops, hold on, people are running things in. Effectively understanding and treating patients with autism. It's been a great collaboration. I think that's a really important concept about training medical students before they get in the field. Are there any efforts that are going on in any of your two agencies around that?
So within the Medicare-Medicaid Coordination Office, we partnered a few years ago around improving social work curriculum. And I know that there is ongoing work, not necessarily within CMS, but more in on the academic side. For example, the Ohio State University that I mentioned, they're doing a lot of work in this area. And actually, if you take a look at the Disability and Health Journal article that I mentioned, there is information in there about examples of where the curriculum is being implemented as far as like different medical fields. So it's slow, but it's a growing it's growing, and it's definitely recognized that we need to introduce it as healthcare professionals are being educated, at the front end. So definitely something that we're interested in, and we look to partner where we can. Although CMS is not. This isn't like CMS's direct purview, but we definitely support it and know that there's work going on in this area.
All right. Next question. We offer assistance to the Camp Fire survivors located in Northern California through disaster case management. Is there a step-by-step process for DCMs to provide to clients? We are working in a unique situation. Thank you for this. This is wonderful.
So I'm wondering if it's DCM, I'm not sure what that acronym is, or
Disaster case management.
Disaster case management. Okay. That is not something that I'm aware of that CMS has direct resources on, but it is something that HRSA may have resources on that. I'm not sure.
And also SAMHSA, Substance Abuse Mental Health Services Administration, has a disaster services resources as well.
And both of those agencies do work more directly with states and regions through grantee programs to provide those kinds of resources.
All right. The next question, I'm going to sort of shorten a little bit for time, but the Office of Civil Rights, and I'm assuming, I'm not sure if this is HHS Office of Civil Rights or FEMA Office of Civil Rights, but anyway, issued an order that required hospital visitation regarding allowing a family member as an attendant for patients with intellectual, developmental, or cognitive disabilities, communication barriers, or behavioral concerns. Why has the OCR, I'm thinking maybe this is not OCR, OMH and CMS not issued the same guidance to allow nursing home residents to utilize family members as the auxiliary aid of their choice?
So this is another policy question that it would be helpful if the person would contact one of us directly or both of us directly. This is not something within our area. I do know that generally speaking, we try to align across agencies within the department, but also recognize that that doesn't always occur as it should. So if that person could reach out with more information, that would be helpful.
All right, very good. Well, we realize that many of you may still have questions for our speakers, and apologize if you did not get a chance to ask your question, but there is their contact information right there on the screen, and you'll be able to contact them with your question directly if you would like, or if it's an ADA related question, Americans with Disabilities Act related question, you can contact your regional ADA center at 1-800-949-4232, and those can be confidentially answered by the technical assistance staff across the country on that. You will receive an email with a link to our online session evaluation. Please complete that evaluation for today's program, as we value your input and want to demonstrate the value of this to our funder. We want to thank Karen and Sonia today for sharing their time and knowledge with us. And a reminder that the session was recorded and it will be available for viewing next week at adapresentations.org in the archive section of the healthcare area. Because the next 2 months, the Thursday falls during the fourth Thursday of the month falls during the holiday season, we will have our next healthcare and ADA inclusion of persons with disabilities webinar in January 2021, and it will be the U.S. Access Board. So watch your email 2 weeks ahead of time for the announcement of the opening of registration for that webinar. So Karen and Sonia, once again, thank you very much for sharing your time and your knowledge with us and your expertise. And for all of you who attended today, thank you very much for attending and have a great rest of your day. Bye-bye.